Hello, students. I welcome everyone for the second anatomy practical live session. So I hope last time you had enough and more of understanding about the topics which we discussed last time, and we had some couple of students who asked for the dissection of two topics from the previous week also. So today, this week, we have come up with some videos which will include even some topics from the previous week since we had a request. And we have come up with anterior abdominal wall dissection video, inguinal canal dissection video, and finally posterior abdominal wall dissection video today. So ma'am, can we start the videos, playing the videos?
Yes. First
Yeah.
video we can start with.
Yes. So I request, no, before that, are we ready, students, with your pen, books, everything, to write down all the things? Can we go? Thumbs up. All right,
Yes.
great. Okay, so I request our technical host to just play the video of anterior abdominal wall.
Hello students, today we are going to see the layer by layer dissection of anterior abdominal wall. So the first layer here is the skin. I reflect the skin, and the next layer what we see here is the superficial fascia. In this cadaver, the superficial fascia is thick, having lot of fat. So we reflect this layer, the superficial fascia, we come to see the flat muscles of abdomen. So the first flat muscle that you see here is the external oblique muscle. So we can identify the external oblique with the help of the direction of fibers. The fibers are directed downwards, forwards and medially. Now as you can see here, the fleshy part of the muscle is situated laterally. When it runs medially, it is ending in a thick aponeurosis. So the first muscle after reflecting the fascia is the external oblique muscle. Now we need to remember two important features of this external oblique muscle. One is that the aponeurosis, the lower border of it, gets folded here to form a ligament called inguinal ligament. And this inguinal ligament extends from anterior superior iliac spine to the pubic tubercle. So this is the inguinal ligament which extends from the anterior superior iliac spine to the pubic tubercle. So the first modification or the first feature of the external oblique is the inguinal ligament. The second modification is the presence of an opening here. You can see here this opening of the external oblique aponeurosis is called superficial inguinal ring. And if I enter through the superficial inguinal ring, I am entering into a oblique canal called inguinal canal. Now, inguinal canal in males is made up of spermatic cord. The content is spermatic cord. So, you can see the spermatic cord emerging out through this superficial inguinal ring. So, the first layer of muscle is external oblique, having two important features. One is the inguinal ligament and one is the superficial inguinal ring. And through the superficial inguinal ring, we can see the spermatic cord emerging out. So, that is about the first layer. Now, I reflect the external oblique. The next layer we see here is the internal oblique. You can see here the fibers of the internal oblique are running upwards and medially, and same like external oblique, medially they end in an aponeurosis. So this muscle is the internal oblique. I reflect the internal oblique. I see the next muscle, that is transverse abdominis. As the name tells, it has got transversely running fibers. Now an important point for you to remember, between the internal oblique and the transverse abdominis, the plane or the space that is present will contain the neurovascular bundle. That is all the nerves and the arteries which are going to supply the anterior abdominal wall. You can see here, it runs between the internal oblique and the transverse abdominis. So this area is considered as the neurovascular plane of the anterior abdominal wall. Now, after reflecting the transverse abdominis, we come across a fascia called fascia transversalis. So, to summarize, we have the first layer, that is the skin. First is the skin. Once we reflect the skin, we have the superficial fascia. The next flat muscle what we see is the external oblique. I told you there are two important things to be remembered here. The lower border of the aponeurosis get folded to form inguinal ligament, and there is an opening here called as superficial inguinal ring. Then the next layer is the internal oblique, and the next layer is the transverse abdominis. An important point, between internal oblique and transverse abdominis, we have all the nerves and arteries that supply the anterior abdominal wall.
Uh, Thank you for doing that video playing without any issues from the technical side. So students, now over to you and Dr. Meera. It's time of discussion with the anterior abdominal wall. Yes, we know we already had a very, short and crisp discussion last week. But in case you have any doubts that has popped up after seeing the video, it's time to ask your questions. Over to you. And ma'am, if you would like to ask them any questions, even that is okay. You can just pop up some questions and let them try answering it.
So I hope you have seen the video clearly. So we have the flat muscles of abdomen. Can anybody tell me where is this neurovascular play? Between which two muscles? The nerves and arteries. Yes?
Please try answering the question. Even if it's wrong, it's okay. We can learn by making mistakes. It's okay.
Yes, correct. Karunamai, very good. Yes, between internal oblique and transverse abdominis. Important because all the arteries, you have epigastric arteries, the veins, the nerves, everything runs between these two muscles. So whenever we are planning for a surgery, we have to know this neurovascular plane. So where exactly to locate for the blood vessels and nerves, correct? Any doubts?
Students, if you have no doubts and if we are good to go to our next video, please put up in the chat box or put up a thumbs up in the reactions.
See, 2-3 points to be remembered here. I hope you have understood. One is the neurovascular plane. Second is about the inguinal ligament. Which muscle is getting modified to form inguinal ligament? The lower border of which muscle? External oblique, correct. External oblique, the lower border gets folded to form inguinal ligament. From where to where is this inguinal ligament? Extend. It is from, very good, anterior superior iliac spine to pubic tubercle. So the modifications of external oblique, one is inguinal ligament. One more, anybody? What is another modification or another point to be remembered in external oblique? Superficial inguinal ring, correct. Why is it called ring? Is it a misnomer? Is the opening rounded? What is the shape of the superficial inguinal ring? No, it is actually triangular. The superficial inguinal ring is a triangular opening. So superficial inguinal ring, the name what we tell, it is misnomer actually. So it's a triangular opening that we see in the external oblique aponeurosis. Very good. So these are the main points what you should remember.
Okay. Yeah, I think everybody is so much into the topic. All are answering very good and equally participating. Arun, Karunamai, and Tababrata. I hope your name is pronounced right. Pardon me if it's wrong. So are we good to go to our next topic? Shall we move on? Yes. Okay. So, ma'am, shall we move on once again?
Yeah.
The extension of external oblique muscle. Ma'am, can you just repeat that particular topic for our Arun?
Okay. So, Arun, the first muscle of our anterior abdominal wall is external oblique. So, actually, if you have gone through the origin and insertion of the muscle, you know that it takes origin from the ribs, lower 8 ribs, it takes origin, and the fibers are running downwards, forwards, and medially. So, the muscle takes origin from the ribs and it runs down. So, the direction is downwards, forwards, and medially. So the extent is from the ribs to the inguinal ligament or to the iliac crest. Did I answer your question, Arun? Okay.
Great, great. Good to know that Arun is clear with his doubts. So are we good to move to the next video then? All good? Thumbs up? Great. Ma'am, shall we move on to inguinal
Yes,
canal?
yes. Yes,
Yeah.
yes.
So I request our technical host to play the second video of the day, which is inguinal canal.
Hello students, in this session we will have a surgically important topic, that is inguinal canal. So you all know about inguinal canal. What is inguinal canal? So inguinal canal is a very small, about 4 centimeter in length, an oblique canal. It is not a straight canal, it's an oblique canal just above the inguinal ligament. You can see here, this white one is the inguinal ligament. What is inguinal ligament? We have discussed about inguinal ligament in our previous videos. The inguinal ligament is the lower border of your external oblique aponeurosis. So this is inguinal ligament. So inguinal canal is a oblique canal above the medial half of the inguinal ligament. So this is the inguinal ligament just above the medial half of the inguinal ligament. We see a small oblique canal called as inguinal canal, and the length is about 4 centimeters in length. That's all. It's only 4 centimeters in length and it is oblique. So 3 points to be remembered here. Inguinal canal is oblique canal. It is 4 centimeters in length and it is above the inguinal ligament. Now coming to the boundaries of that. So inguinal canal will have an anterior wall, it will have a posterior wall, the roof and the floor. It's a small one, it's like a box having an anterior wall, the posterior wall, the roof and the floor. Now coming to the anterior wall, this is the anterior wall. So anterior wall is formed fully, entire extent by external oblique aponeurosis. This is the external oblique aponeurosis. I reflect the external oblique. Now laterally, the inguinal canal is formed by the fleshy fibers of internal oblique. So this is about the anterior wall. Once again, the anterior wall is formed by the first one called aponeurosis. Which muscle aponeurosis it is? It is the aponeurosis of external oblique. Now below that, laterally, the anterior wall is formed by fibers of internal oblique, this one. So the anterior wall is formed by 2 structures. From outside to inside, it is aponeurosis of external oblique, and laterally by internal oblique. Now the roof of the inguinal canal is formed by the fibers that are arching. You can see here the arching fibers of the internal oblique and the transverse abdominis will form the roof of the inguinal canal. So can you see it properly here now? This is our internal oblique. The few fibers of the internal oblique are arching here and it is joined by transverse abdominis. So I take it as one component. The roof of the inguinal canal is formed by arching fibers of internal oblique and transverse abdominis. Now the posterior wall, this is the posterior wall, and this yellow color one is a fascia. So the posterior wall is formed by a fascia called fascia transversalis. Fascia transversalis. So just we'll see from the beginning, the inguinal canal has got a anterior wall, the posterior wall, the roof and a floor. Now anterior wall is formed by, first one is the aponeurosis, yes, external oblique aponeurosis, and laterally it is by the fibers of internal oblique. So anterior wall of inguinal canal is formed by 2 structures. Along the entire extent is by external oblique aponeurosis, only laterally by internal oblique. Now going to the roof is formed by the fibers of the muscle which are arching. So we put it as arching fibers of internal oblique and transverse abdominis. So I repeat, the roof you can see here, this is the roof which is formed by arching fibers of two muscles, internal oblique and transverse abdominis. Now going to the posterior wall. What forms the posterior wall? Just now we mentioned, it's a fascia. The fascia is called as fascia transversalis. Now going to the floor. This is the floor. The floor is formed by a ligament called inguinal ligament, and this ligament is extending from anterior superior iliac spine to the pubic tubercle. So this is the inguinal ligament. So anterior wall, the roof, the posterior wall and the floor. Now we are inside the inguinal canal. You can see here we have already entered into the inguinal canal, and I can see the contents of the inguinal canal here. Any idea what are the contents of inguinal canal? It is, in males, spermatic cord and ilio-inguinal nerve. You can see here there is a thin nerve here. This is the ilio-inguinal nerve, and below that this is the spermatic cord. So in males, the contents of the inguinal canal are spermatic cord and ilio-inguinal nerve, whereas in females it will be round ligament of uterus and ilio-inguinal nerve. So these are the contents of the inguinal canal. Now the inguinal canal has got a outlet and an inlet. So this is the outlet. Now if you see here, this is the outlet. The outlet is formed by a ring, a triangular opening here. This triangular opening is called, where the spermatic cord is coming out, this triangular opening is called superficial inguinal ring. This is the superficial inguinal ring, and through the inguinal ring you can see the spermatic cord emerging out. So the outlet of the inguinal canal is formed by superficial inguinal ring. And going to the inlet is in the posterior wall. I will reflect layer by layer. Now you can see here the spermatic cord is emerging out. You can see a small opening here. This is the deep inguinal ring. So deep inguinal ring is the inlet of the inguinal canal, and it is about 1.25 centimeters above the mid-inguinal point. This is the mid-inguinal point. 1.25 centimeters above the mid-inguinal point is the deep inguinal ring. So to summarize, this is a small canal called as inguinal canal, and the inguinal canal has got an anterior wall, posterior wall, roof, floor, inlet and outlet. Now the anterior wall. So the anterior wall is formed by, can you tell me what forms the anterior wall? It is formed by aponeurosis of external oblique and laterally by internal oblique. Now going to the roof is formed by arching fibers of internal oblique and transverse abdominis. The floor is by the inguinal ligament, and the posterior wall is formed by a fascia. The fascia is called fascia transversalis. Now there is two openings. One is the inlet and one is the outlet. This is the inlet. So inlet is called as deep inguinal ring, which is an opening in the fascia transversalis. Now how to locate this? Where exactly this opening is in a patient? It is about 1.25 centimeters above the mid-inguinal point. So this is the deep inguinal ring. Coming to the outlet, this is the outlet. So outlet is in the external oblique aponeurosis, and that is called as a superficial inguinal ring. So this is about inguinal canal boundaries. Coming to the contents, in males there are two contents. One is the spermatic cord and ilio-inguinal nerve. In females, it is the round ligament of uterus and ilio-inguinal nerve.
So students, how did the inguinal canal video go? Did you understand? I think it is one of the most important topics. Like it's even a 10 marker for the exam, as well as it can come as points for, dissection wise also, they can have questions in practical side also. So Arun has a question, ma'am. Ma'am, once again, the contents of male and female inguinal ring. Ma'am, can you repeat it for them again?
Yes. So Arun, the inguinal canal in males, actually this canal is formed because of the descent of testis. So in an infant or in a fetus, before birth, the testis is in the posterior abdominal wall. So what it happens is it starts descending. The path taken for the descent of the testis is like a canal, and we call it as a inguinal canal. So the testis has already descended to the scrotum. So, but the spermatic cord will remain in the inguinal canal. So that's why in males, this inguinal canal is wider. We say that in males it is wider because the main content in the inguinal canal in males is spermatic cord. And there is one nerve also called ilioinguinal nerve. Whereas in females, the ovaries are descending, but it descends to the pelvis. Okay, it will not go to the external genitalia. So the spermatic cord is replaced by a small ligament in females called round ligament of uterus. The nerve remains the same, that is ilioinguinal nerve. So contents are two different in case of males and females. The nerve is the same, called ilioinguinal nerve in both males and females. Whereas in males, the main content is spermatic cord. In females, it is round ligament of uterus. Is it okay, Arun?
Arun, is it clear? Yes, I think that is the beauty of this subject also. If you try to learn that, okay, contents in males is this too and contents in females is this too, it's never going to be there forever. But once you learn what is the reason why this happens, and everything has a reason in this subject, you have to learn this anatomy subject like that because it is something which is going to persist throughout your career. Wherever you go, you need to have an idea about the first year subjects, my dear students. It's from my personal experience also. So better you learn that like this, like how ma'am actually explained. And we also have Kulsum with a question, ma'am. She wants an explanation for the inguinal ring again. So can we help her with that, ma'am?
Yes. So Kulsum, we have two rings here, inguinal canal. We call those rings as inlet and outlet. One is in the anterior wall. One is in the posterior wall. So imagine the inguinal canal as a box. So there is an outlet and an inlet for that box. So inlet is in the posterior wall and outlet is in the anterior wall. So anterior wall, what forms the anterior wall? What structure forms the anterior wall? The entire extent of the anterior wall is formed by which muscle? Which aponeurosis? Which aponeurosis form the anterior wall? It is external oblique, right? Yes, external oblique. So what happens is that this external oblique is showing a gap or an opening, which is triangular in shape. And that is called superficial inguinal ring. So in a patient, when he comes with a hernia, so we need to examine him. So where exactly I will look for the superficial inguinal ring? I will first identify the pubic crest. That is a bony landmark called pubic crest. Just above that will be the superficial inguinal ring. So I repeat, the superficial inguinal ring is an opening in the external oblique aponeurosis. It is present in the anterior wall of the inguinal canal. And surface marking, if I have to locate it on the surface, it will be just above the pubic crest. And the shape, even though it is called as a ring, it is triangular in shape. So these are the 4 points you can remember for superficial inguinal ring. It's a triangular opening in the external oblique. It is just above the pubic crest and it is in the anterior wall. Coming to the deep inguinal ring is just opposite to that of the external oblique. That means it is not triangular, it is rounded. It is in the posterior wall. So what forms the posterior wall of inguinal canal? Is it a muscle or a fascia? Yes, it's a fascia. What is the name of that fascia? Fascia transversalis. Very correct, Karunamai. Fascia transversalis, correct. So in the fascia transversalis, I'm seeing a rounded opening called as deep inguinal ring. Now again, in a patient, I need to locate it. That is about 1.25 centimeters above the mid-inguinal point. So 2 things to remember here. So mid-inguinal point and midpoint of inguinal ligament. You already know that inguinal ligament is from pubic tubercle to anterior superior iliac spine. So if I take a midpoint of that, I call it as midpoint of inguinal ligament. Here I'm not referring to that. Mid-inguinal point means it is the midpoint between anterior superior iliac spine and pubic symphysis. Yes, very correct, Karunamai, very good. You're right, pubic symphysis and anterior superior iliac spine. So if I get it, 1.25 centimeter above that is my deep inguinal ring. So these are the two, superficial and deep inguinal ring. I hope you have understood.
I think that's something very important because we all had a doubt on this midpoint and mid-inguinal point. It was always a viva question for us, and we used to tremble in front of our examiners. So I hope our students will not have that thing. I think we have a question from Tababrata. Ma'am, what is the conjoint tendon in posterior wall?
Yes. So actually, conjoint tendon, I told you that the posterior wall is formed by fascia transversalis. Now, if you remember, I told the roof is formed by arching fibers of internal oblique and transverse abdominis, right? So this arching fibers, once they arch, it goes back. That means it merges with the posterior wall. So once it merges with the posterior wall, we call it as a conjoint tendon. So it is nothing but arching fibers or the fibers of internal oblique and the transverse abdominis put together is called as conjoint tendon. But we don't tell it in the roof. We don't call it in the anterior wall. Only once it reaches behind or in the posterior wall, it is called conjoint tendon. So conjoint tendon is the fibers of two muscles, internal oblique and transverse abdominis.
So is it clear, Tababrata? Yes. Okay. Okay. Any other doubts, guys? Any questions or any queries? Anything which you need more explanation? So if there is nothing else, is it good to go to our last video of the day? Can I get a thumbs up if we are good to go to the third video?
Okay.
Okay.
Aishwarya, I think we have a question. Kulsum.
Yes, yes.
Yeah.
Regarding the conjoint tendon.
Yes, yes. So Kulsum, I told you that the roof of the inguinal canal is formed by arching fibers of internal oblique and transverse abdominis, right? After arching, the fibers will go and join the fascia transversalis. That is nothing but the posterior wall. Once it goes to the posterior wall, we call these fibers as conjoint tendon. That is the fibers of internal oblique and transverse abdominis. So the fibers of internal oblique and transverse abdominis in the posterior wall is called conjoint tendon. Is that okay, Kulsum? Okay.
Okay, great. So I think then we can move on to our next video, which is the posterior abdominal wall. So that is one of the important topics. See, in this week's schedule, we have more of posterior abdominal wall. Apart from inguinal canal, another important topic is about the muscles of the posterior abdominal wall, the nerves and all those things. So we'll move on to that video. Keep your pen and books ready and write down all important points. I think ma'am is repeating for a couple of times in the video. You can take your time to write it down. But even after that, if you feel you need more explanation, we can still discuss on the topics. So I would request our technical host to kindly play the last video of the day, posterior abdominal wall.
Hello students, today we are just having an overview of the structures that are present in the posterior abdominal wall. You can see here, we have a good specimen here to show you all the structures what are there in the posterior abdominal wall. So you should understand here that all the coils of intestine, the pancreas, the duodenum, everything we have removed. What we are seeing here is only the right and the left kidneys and the suprarenal glands. So shall we start now? So we'll just start from the midline. The red colored one is the abdominal aorta. in the center of the body, in the center of the plane, we have the abdominal aorta. You can see here it goes down and divides into right and left common iliac arteries. So, the first structure of the posterior abdominal wall is abdominal aorta dividing into right and left common iliac arteries. Now, to the next of that, we can see a vein. You can make out this is vein because of its collapsible lumen. This is inferior vena cava. So, to the right of the abdominal aorta, we see the inferior vena cava, and going to the right side, next to the inferior vena cava, this is the right ureter, right ureter. Then we see some muscles here. Next are the muscles. First one, just medial or just to the right of the inferior vena cava, the first muscle here is the psoas major. Psoas major. Next to that, this is the quadratus lumborum, and the last one here, this is the transverse abdominis. So, shall we see it once again? We have started from the midline and we are moving laterally. So, in the midline, the first structure what was seen is the abdominal aorta. To the right of that, we saw the inferior vena cava. Very next to that, we have the right ureter. Then comes the muscles. We have three muscles in the posterior abdominal wall. This is the psoas major, this one. Next is the quadratus lumborum, and what I am holding here, this is the transverse abdominis. Now we have lot of nerves. If you see here, if I lift this kidney, you can make out there are lot of nerves that we can see here. All are in relation to this psoas major muscle. Now lateral to the psoas major, we see one thick nerve. This is the femoral nerve. Now above the femoral nerve, we see the next second nerve, that is lateral cutaneous nerve of the thigh. So femoral nerve, just above that, this is the lateral cutaneous nerve of the thigh. Then we can see much above that, we have two nerves here. This is a ilio-inguinal nerve and ilio-hypogastric nerve. So ilio-inguinal nerve is thinner and ilio-hypogastric is the thicker nerve, and they come behind the kidney. If I place the kidney like this, these two nerves are the posterior relations of the kidney. Now I go medial to the psoas major. We see a nerve here. You can make out this nerve is the obturator nerve. This is the obturator nerve, and on the psoas major, you see one thin nerve here. This one, there is a thin nerve here. This is genitofemoral nerve. This is called genitofemoral nerve. So we have many structures in the posterior abdominal wall. Each one is important. So starting from midline, this is abdominal aorta. This is inferior vena cava. Next to that, we have the right ureter. Then comes our muscles, medial to lateral. First is psoas major. Then you have quadratus lumborum. Then we have the transverse abdominis. Then coming to the nerves in the posterior abdominal wall, the thickest nerve which is seen is the femoral nerve. Above that, we have the lateral cutaneous nerve of the thigh. Then I just lift the kidney. You can see two nerves, one thin one called ilio-inguinal nerve and the thick one called ilio-hypogastric nerve. Now if I go medial to this psoas major, I see the obturator nerve, and on the psoas major we see the genitofemoral nerve. These are the main contents what we see in the posterior abdominal wall once we remove the intestines, the pancreas and the duodenum. Now once we know the structures which are there in the posterior abdominal wall, let us have a quick view into the muscles which are present in the posterior abdominal wall. Now starting from the middle, that is the median plane, going laterally, we have three muscles here. The medial most one is the psoas major, what I am holding now and showing you. This is the psoas major muscle, and inferolateral to the psoas major, inferiorly and laterally, the small triangular muscle you can see here, this is iliacus. Above that, we see the quadratus lumborum muscle. This is the quadratus lumborum muscle, and more laterally is the transverse abdominis. So let us see once again from medial to lateral. The muscles are not of the same distance or same size. So we have a very big muscle medially. This is the psoas major. Next to that, inferolateral to the psoas major, we have a small triangular muscle. This is iliacus. Just above that, we have another muscle that also lies lateral to the psoas major. This is quadratus lumborum, and more laterally is the transverse abdominis. Now, if you see the psoas major, it's a quite big muscle going on either side of the vertebral column like this. The fibers, you can see it is running down inferolaterally. The fibers go behind the inguinal ligament and they reach the thigh to get inserted to the lesser trochanter of femur. So, this is our psoas major muscle here. Now, inferolateral to the psoas major, there is a small triangular muscle, this one. So, just now I told you this muscle is called as iliacus. So, this is the iliac crest. This is a bony landmark called iliac crest. The muscle will come below the iliac crest. So, this is the iliacus muscle taking origin from the iliac fossa, and most of the fibers of the psoas major and the iliacus are merged together. That means the iliacus muscle come and join with the tendon of psoas major. Now, once they join together, we call them as iliopsoas. They are mentioned as together in our books called iliopsoas. So, the minute I tell iliopsoas, I am including two muscles here. One is psoas major and one is iliacus. Both will run down to the thigh and they go to the lesser trochanter of femur. Now, why is this important for us? The iliopsoas muscle has got very important relations to the ureter. The ureters, if present, the cecum, the appendix on the right side and the sigmoid colon on the left. So, they have an important relation with these organs. So, any inflammation of the ureters, the cecum, the appendix or the sigmoid colon, the patient will complain of pain while movement of iliopsoas. So, it's a very important test that we do in clinical side, the iliopsoas test for any pain. If the patient complains of any pain while movement of the iliopsoas, we can consider that there is some inflammation of the mentioned organs. So, the organs I mentioned was the ureter, the cecum, the appendix and also sigmoid colon on the left side. So, the first muscle what we saw was psoas major. Inferolateral, below and lateral to the psoas major was our iliacus muscle. Both are running together. So, since they are running together and joining together, it is called iliopsoas and they go to the lesser trochanter. Now, above the iliac crest, this muscle is quadratus lumborum. The quadratus lumborum also arises from the lumbar vertebrae and they get inserted to the iliac crest. So, that means it is ending at the level of iliac crest. This is the iliac crest. So, this muscle lateral to the psoas major is quadratus lumborum.
So, is it clear, students? Over to you for any kind of queries. Ma'am is all ready to answer you. Yes, it is clear. Arun says he's clear with it. And any doubts before we conclude the session? Any doubts from anyone? And also do let us know if you want any, want to give us any kind of valuable feedback. Because since these are shot on real cadavers, yeah, we have a question. What we do in iliopsoas test?
Yeah, actually, iliopsoas test is where we have to know the action of psoas major. The psoas major and iliacus will cause flexion of the hip joint. So, whenever you ask the patient to flex the hip joint, he will wince with pain. Okay, if there is any inflammation of those organs. So, we call it as iliopsoas test. So, the main action when we try to perform it on a patient with any inflammation of these organs, that is flexion of hip, he will have pain. So that is positive iliopsoas test. So,
Tababrata, is it understood? Ma'am, any easy way to remember origin and insertion of muscles?
Yes, we can, with Dr. Aishwarya, I think we'll have to look into this. We can make it easy for them.
Sure. Definitely, dear students, I think that is my headache. I'll come up with something for you guys. Give me a couple of time because I'm also coming out of a very small respiratory infection. So just a couple of days for me, and I'll definitely bring up something for you guys. You are going to be with us for the next 90 days and even more. So in this marathon, we are also acing with you guys. So I'll definitely think about this. Ma'am, we can sit down for a discussion on how to make
Yes,
it
yes.
little
We'll
easier for
surely
them.
do it because if they have to build a building, their foundation has to be very strong. And that
Very
is
true,
nothing
very
but
true.
anatomy.
Very true. Don't worry, my dear students. We will work on it. We will get back to you with how it can be easier. So before I sit seriously for it, I would just like to know, do you guys love to listen to these videos or these kind of things and learn, or you would prefer some kind of a handbook or something like that where you get all these origin insertions and, the quick notes of something like that? What are you guys preferring, or what are you guys looking up to? Okay, so some kind of short videos like this to remember is what you are looking forward for, Karunamai. Okay, okay, okay. Definitely, we will work on this. I think that is one of the concerns of any first year MBBS student, and not even first year. I struggled when I was even in final year or internship during ortho and all. I don't know, my internship was really bad because of this origin and insertion. We used to sit numb in the rounds. So I truly understand. We will work on it. We can work on it. No worries. Any other doubts regarding the topic which we discussed today? And also, I would like to get a small feedback on the videos. Like, are you guys able to understand? Do we need to make any changes so that it'll be better? The experience will be better for you guys. Is there anything which you are looking forward for while we record the videos? Because these are recorded on live cadavers. We have to implement it when the next recording happens. So yeah, very understandable. Thank you so much, Arun. Means a lot for us. Um, so are there any other queries or any feedbacks? If we are good to wind up, then we can just consider this as a day. Great, great. Thank you so much, Kulsum. It was, we are also equally happy that you guys are answering to our questions and,
Yes.
letting us know what you are actually understanding from the session. It's really informative. We are also happy that it's making some good use for you people. Keep attending all the sessions. This will really fetch you a lot of things. I wish if I had something like this when I was in first year. So we have a doubt, ma'am. Ma'am, is all the structures which passes through the superficial inguinal ring come through the deep inguinal ring? Tababrata has asked.
Yes. Tapaprata, actually, it's only spermatic cord. Spermatic cord enters the inguinal canal through the deep inguinal ring and comes out through the superficial inguinal ring. So ilioinguinal nerve will be piercing the posterior wall and entering. So it is not through the deep inguinal ring. So if hernia occurs, they follow the path of the spermatic cord. So I told you the inguinal canal is formed by descent of the testis. So testis and spermatic cord descends together. So whatever the path taken by the spermatic cord will be the path taken for the inguinal hernia. So it's only the spermatic cord which passes through both the rings.
What a sensible doubt. Very good, very good. Please keep asking these kind of doubts. It's okay to have doubts. It's actually very normal to have these kind of doubts, and you have a very good platform. Meera ma'am is so friendly. She'll clear all your doubts. No problem. Okay. So can we call it a day, guys? If everybody, Taba brother says thank you so much. Oh, Fatima is saying I'll also tell my friends to join. Great, great. Thank you so much, Fatima. Please do tell all your friends that we are having all these kind of sessions in our marathon program. Let us all learn together in this marathon. So, yes. So I think, can we wind up, ma'am, then?
Yes, yes.
Anything?
If
so
they
guys,
don't have any doubts, then we can.
Yeah, sure. So this week, the schedule is already shared. Daily 2 topics is what you have to learn. keep learning it accordingly. Make studies a habit, because MBBS is all about, making that curriculum a part of your life. That is all it is. It's not about smart or hard work or nothing like that. It's about making it a part of your life. Enjoy the process of learning. Don't make it like a burden. Just make it a part of like your life, like you eat a biryani a day, or you eat your meals, fish curry meals your day, or something like that. It's just something that you do every day. So every day, just 2 topics is what um, you will be having. Just go through the topics through our pre-recorded videos, come back, sit for the anatomy live session where you will have all the practicals discussed, get your FAQs at the end of the week on Saturdays, and the next Monday, do attend the session where the potential NEET PG questions will be discussed on Monday. Where schedule is shared, please do contact your POC. I think you all have a POC, right? I can't find your name. I can find only your phone name, Redmi. So you all are in contact with your POCs, right? Can I get a thumbs up if it is yes? Yes. Yes. Please do contact your POCs. They will share you the schedule. Take up the schedule and just learn it accordingly. Nothing. You don't have to do anything. Just come back from the college, go through the schedule, read or attend the videos, whatever is mentioned in the schedule, attend all the live sessions, do the Q banks, whatever is there in our Learnist platform, in our LMS platform, and keep it as a habit. That's all. It's going to be really easy for you. A cakewalk, I would say. So we will meet very soon next week with the next week's session. So until then, ma'am, where can I get the Q bank? Kulsum, Mondays we will have a discussion, right? We have a discussion where potential NEET PG questions will be discussed. Okay, after that session, within a couple of days, maybe before Wednesday, this will be there. The whole Q bank will be put up in the Learnist platform, in your LMS platform. I hope you know about the Learnist. Do you know about it? You've already registered? Yes, the web platform. Exactly. Exactly. Have you registered to the web platform? Okay, please do have a discussion with your POC. Your POC will guide you through the whole process. Register to that web platform. In that web platform, we are uploading a lot of things for you, like the potential NEET PG questions, which comes up as a Q bank for you guys. You can attempt the questions and, check out the keys if it's right or wrong and understand where you went wrong in all these topics. And also we will be uploading a set of frequently asked questions. Like for example, today we discussed all these topics, right? Inguinal, canal, anterior abdominal wall, posterior abdominal wall. Now you would be wondering how questions will come up for your exams, for your second internals or for your university exam. Inguinal canal can be a 10 marker. Sometimes it can come only, the contents of inguinal canal only can be asked as a 2 marker. So how the different questions can pop up for your exams will be shared to you as a frequently asked questions also. Take up that questions also, understand how the questions can come, what all permutations and combinations will come from all these topics. Make sure every learning loops are closed in a week with all these topics. So it is there for all the 3 subjects, not only for anatomy, physiology and biochemistry also it is there. Okay, someone is asking when is next ward rounds by Sanjit sir. Hopefully, we will meet very soon. I think next week, Ryan sir is coming up with ward rounds. So because they are surgeons, we do not know. Sometimes if some emergency case comes up, it can get postponed or, it can get interchanged. But next week, we will have Ryan sir. And the week after that, we will have Sanjit sir back to the ward rounds. I'll definitely let Sanjit sir know there is a fan from this batch. And how many Meera ma'am fans are there? Get a thumbs up or a heart in the reactions. Me. Oh, Arun says it out. Kulsum, Fatima. So all are your fans also, ma'am. Happy to do that.
Thank you. This is what we want at the end, no? Our students are happy.
Great, great. I have no doubt on that. They all are equally happy with your class. We will definitely meet up for the next session. Stay tuned. Keep it's about consistency. Consistently keep learning. It will come on your track. Don't worry, guys. Just write down all the things what we learned today. Read it tomorrow. Just, while you travel in a bus or something, just make sure you just read it so that you do not forget. Everything what you learn, if you make an effort to just go through that within 24 hours, it gets registered even better in your memory. That is what experts say. So before 24 hours, if you make an effort to just revise what you have gone through, that is going to be there. Okay, so that is a tip for the day, and I'm going to call it a day. So thank you so much, Dr. Meera. It was such a wonderful time interacting with you and as well as our dear students. I hope everybody enjoyed. And let us conclude the session today. We'll meet for the next week with yet another set of topics. Until then, it's bye from both of us. Bye, guys.
Thank you. Bye.
Good night.